Let's talk about who pays for hospice. It's a big question that comes up. 98% of your hospice patients are covered under Medicare. So if you are Medicare eligible due to age or condition, you have paid into that hospice benefit all of your working life. So every time you paid into FICA, I believe is FICA, that goes towards Medicare and Medicaid. Let's talk about Medicare first because that's really the guidelines that we use through all different types of payer source because it's just safer that way. You follow the Medicare guidelines for every single patient. It just helps keep everything on track. So Medicare covers 100% of the cost of hospice companies. Reputable companies will put this in writing, saying that if you are a Medicare patient or Medicaid patient, they will only accept what is paid for by Medicare for your services. We do realize that for some patients, a very small amount, maybe 4%, will be very expensive due to medications, supplies, those kind of things. But the average patient, you can cover all of your costs for your hospice benefit under Medicare and then some. I'll get into that part later. But Medicare is your biggest part. Medicaid also has a hospice benefit associated with it. This does require a few more steps from the hospice because you have to be approved by Medicare as a provider, and that plan of care that's developed for that patient has to also be approved. They have to put that stamp on it in order for payment. So Medicare and Medicaid is, a good portion of the payer sources for hospice. Private insurances, you actually have to elect that if you are younger, working age, and you have health benefits. You have to elect hospice coverage for a certain amount of time before you can take advantage of that. So it's a lot like getting the prenatal package of your health care plan. Hospice also has to be elected that same way, and it is an extra cost for that. So with my health insurance, I do have a health care plan, and I do pay extra for hospice care, cancer care, those kind of things because, I'm a single person. So being covered by insurances is really how we protect ourselves. So look into that. Not that everybody wants to be a doomsday, person, but you just never know when that diagnosis is going to come. And most health insurance, private insurance companies will not cover extra costs associated with a pre-existing condition. So have a talk with your insurance provider, your health care providers, about what this should look like for you if you are young. I have taken care of quite a few young people, 30s, 40s, 50s is still young for me because I'm almost there myself, who didn't have that part of their health insurance elected, and they do have life-limiting conditions. So that is a big thing to look at when you're looking at your health insurance benefits. A healthy hospice company will also have a indigent program or a patients that will never have the ability to repay you. We see that with a lot of our homeless people, or we see it at younger aged people who have been sick for a while. They have lost their employment. Disability has not started yet. They are life limiting and they are not currently covered. I have been in situations with hospices where they have declined these type of patients because putting out that type of expense was more than what their bottom line can cover. But your hospitals and your doctor's offices, those kind of folks, know which programs can take indigent patients. And it is a good way to give back. Indigent patients or patients who don't have the ability to pay should be, and in my experience has been, treated this very same way as a patient with private insurance, Medicare or Medicaid. We all kind of follow the same guidelines for these type of patients. So that is payment. Um, I have heard horror stories and I have seen horror stories where that family really believed that that patient was covered at 100%, but once their loved one passes, then they start getting bills for medications, for supplies, or whatever. You have to really ask those questions on the forefront when you're signing on to a hospice or when you're interviewing hospices. Is there any bills that I need to be aware of that can come out of the woodwork that are not covered by my insurance or Medicare or Medicaid? With that being said, let's go into what should be covered. A healthy hospice company should be covering your DME or your medical equipment. Those are contracted services. That is not something that hospices have a hospital bed sitting in a warehouse somewhere. We contract out those services here in South Carolina with companies who can provide that. There's a lot of good ones, and I have been in situations where we did not pre-plan and prepare for a crisis event, and I'm on the phone with that medical company saying I need oxygen right now, and the really good companies will be racing to that house the same time that I am. With your medical equipment, you know that you've got a good hospice if we are planning for the worst and hoping for the best. So don't be afraid if your hospice nurse says, well, let's just go ahead and get some oxygen in here for those crisis moments that happen at 2 o'clock in the morning. And, people don't want to be out on the road at 2 o'clock in the morning. So let's prepare. I've seen extremes to that too. Here recently, I worked with a fantastic nurse who wanted oxygen in the home, suction in the home, nebulizers, anything that could possibly be needed at that crisis moment. And we don't have to wait for a medical equipment company to deliver those supplies. I've also worked with a doctor recently who thought that suction was really not necessary, and he called them esophageal hickeys because you're suctioning that patient. But I will tell you, when you have a patient that has a lot of secretions, there could be foam coming out of their mouth for a variety of reasons. You want to have that suction readily available so that family can just flip that switch and suction out the mouth and make sure that those symptoms can be controlled. So that is really going to be up to your individual hospice nurse, the hospice doctor, and the hospice company. Hospital beds. That is huge for a variety of reasons. You can sit the head of that bed up, get the air that you need. You can lift the feet up. You can get into a reclined position. Most hospice companies, when you get a hospital bed, you also get one of those wonderful tabletops that roll, right over you. So if your person can no longer get out of bed, but they do want to sit up and try to eat, or they want to sit up and watch TV or read a book, that hospital bed is going to be able to put them in that position along with that over the bedside table to be comfortable, and you can be comfortable. Where I think it's important for staffing is back safety. We have to, as healthcare professionals and families, be using proper body mechanics when it comes to lifting, turning, or working with a patient, whether it be wound care, placing a Foley catheter, whatever it is. We need to get that bed at a comfortable height so we are protecting our backs. People in healthcare can work 25 to 30 years if we are working with safe body mechanics. I understand a hospital bed seems like it is the last ditch of independence that you are losing. But if you think of the care that we give at the final weeks to days to hours of life, you really need to be able to get to your person and get to that patient using safety for yourself as a family member and for the staff that's coming in to take care of them. I've only had one patient in the past 12 years absolutely refuse a hospital bed because they did not want to die in a bed that someone else could have died in. And I get that. I really get that. But I will tell you, I had to limit the disciplines that I allowed in there and the work that was allowed to be given because this lady was pretty big I mean, probably 250 pounds, and to bend down on a regular bed and lift and turn and tug, that's putting my staff at jeopardy for a back injury that will affect them for the rest of their lives. So I understand the mindset and the fear, but just think that is the one tool that is the most helpful when that hospice team is coming in and helping take care of your loved one. So, medical equipment, you're going to see a variety of different ways to do that one. Medications. Medications that are related to your diagnosis, whether it be heart disease, lung disease, cancer, Alzheimer's, whatever medication that you are taking related to that main diagnosis, the hospice should be paying for. So if it's heart disease, they should be covering that Lasix or your fluid pills, high blood pressure pills, any type of cardiac drugs. If you have a heart diagnosis, your nitroglycerin for chest pains, all of that should be covered by the hospice, along with medications for comfort. So medications for pain, nausea and vomiting, secretions. We see that a lot at the end of life. Those type of medications should be paid for by the hospice. That has to be pre-planned and pre-prepared. You will see a lot of companies use an emergency kit or a comfort kit that is put in the home on admission. That for us is important. Being an on-call nurse for 2 years, that was the toughest thing. Hang on, I got a text message. I don't know if that shows up or not. That was the hardest thing, to know that you were heading to a patient's house and you do not have those emergency medicines that's needed to handle that crisis. And it's 2 o'clock in the morning and all the pharmacies are closed. So I know that that is scary. I know comfort kits, when you mention that word, is pretty scary. It does generally have morphine in it. Morphine we use in a variety of ways. It's not just for pain. Morphine actually relaxes smooth muscle. So anything, your lungs, all of that is smooth muscle. If you are a respiratory patient and you are having a hard time breathing, your lungs are tight, they're closed in, or maybe they're filled with fluid, that little bit of morphine sublingually, it's a tiny little bit, can open up those airways and allow you to take a fuller, deeper breath. We use it in very small doses. It's not the kind of dose that you get in a hospital setting before surgery or even after surgery. It's less than that. It is super concentrated, and it can be given sublingually even when your loved one is comatose. So the way that I like to use it with that is if you're trying to turn a patient and they are very stiff. When we lay in one position for too long, our bodies do get stiff. I'm almost 46 years old and I know that I can't lay in one position for more than 3 hours. I have to turn myself. Imagine you being that person in that bed who cannot physically or have the mindset to know that they should be turning themselves. People start getting contractured. I mean, their arms draw in, their legs draw in. As a nurse, if I am changing or turning that patient or assessing that patient and they are very stiff, then using a little bit of that morphine to relax them, to relax those muscles, make it easier for them to be moved and turned, because that can be pretty painful. I mean, to move somebody and turn somebody when they're in that state. So morphine is a big one. If you have an allergy to morphine, there are other medications that the doctor can order that is on the same line as that. I'm talking about comfort kits here, the comfort pack. For nausea and vomiting, they usually have suppositories, whether it's Phenergan or Compazine. Those can be grabbed in a jiffy. If your patient or your loved one is experiencing nausea, give one of those. There's usually a list of instructions on how to use that medicine, each medicine. So Phenergan, Compazine, very important. Ativan, we do use that for restlessness and agitation. There are a handful of patients who, for a variety of medical reasons, will have some confusion at different points and times during this hospice process, during this death and dying process. Ativan any of those type of medications can be used to also relax that person. We do coincide those medications with morphine, so do not be shocked if your nurse or that physician has prescribed this medication, because it just keeps that body relaxed. It helps that person be able to go through this transition with minimal complications. Not every company uses it. I know back in 2006, the DEA had a real big problem with it because they thought that we were pharmacies and we were trying to dispense medications. When the truth of the matter is, when it comes down to your hospice patient calling that hospice nurse and you know that you've got the tools there to help that patient, versus that hospice family calling 911 and getting their loved one to a hospital setting, which is, I love my hospital nurses, don't get me wrong, that is no place for a hospice patient. The hospice patient should be cuddly and warm and comfortable around their loved ones and at home, wherever their home is. So, comfort packs, secretions. This tends to be a pretty big problem. I would say about maybe 45 to 50% of our patients have that. And I will give my very general explanation of why this happens. As we are in the death and dying process, that transitional period, which is days to hours, we're not eating and we're not drinking. This is really the same through all disease processes, whether it's cancer, heart disease, lung disease, Alzheimer's. It seems like a lot of them really go through that. The death rattle or secretions is the most similar one, and it's the most disturbing. If you've heard it, it can be very disturbing. To me, it's like Rice Krispies when you pour the milk on it and it's snapping and crackling and popping, and you just know they're breathing through fluid. In that comfort kit should be medications of that hospice director's choice on how to treat that. I have my own opinions on it just based on what I've used and what I've seen work, but I am not a physician, so I can't prescribe or say this is the best, because it really is up to that doctor. Let's see. Let me turn that off. Anyway, so secretions are huge. It can happen at any time of the day or night. Generally, it happens at night, and we as hospice people, when we see that, we know that transition, they're going to a whole nother level. Will every single patient have the death rattle or secretions? No, but pre-planning and preparing for you to have that medication readily available when it does happen is huge. And that helps that hospice nurse get you through what that portion of that transition looks like. With that as well, in that comfort kit should be medications for constipation. I would say about 80% of our patients are on some type of opioid. Morphine is an opioid. Tramadol, even the lightweights are opioids, and it does cause constipation. So if we notice that a patient has not had a bowel movement in 3 days, there should be medications in that comfort kit that nurse can grab, administer very quickly. If it seems to help or work, then great. I see a lot of nurses and doctors want to order what we call Colace or docusate sodium. That does nothing for opioid constipation. You really have to have something that has some guts to it, like Senna S or those kind of things. Once again, I'm not prescribing anything. I'm just telling you, if the only thing that your hospice nurse is giving you for constipation is Colace, it's not going to work for you. You're going to be constipated, and that's pretty miserable. So really have these conversations with your hospice nurse on admission. How are you going to help me manage my symptoms? More times than not, a comfort kit will be ordered. You will be instructed, and I've heard it 1,000 times, look, just put the whole box in that refrigerator and don't even think about it. Don't open it, and don't even think about it until you are told to do so. If you are told to break into that comfort pack and that comfort kit to start administering medications, a good hospice nurse will also be on the way. because we realize some of those medications are very scary, and there's a lot of feelings associated with morphine. So that nurse who's instructed you to give it should also be getting in their car and heading towards you, if not soon, by that day. Okay. So medications are covered. Now, let's say you are on heart disease and they've related diabetes to your um, uh, diagnoses or comorbidities. That doesn't mean that the hospice company is going to cover your insulins. It's very rare when I do see that. And that's usually for renal patients. So it will be up to that hospice physician to decide what is related to your overall prognosis, your diagnosis, and your comorbidities, and then what medications are also related. So make sure you ask those questions. Which medications are you paying for, and which medications are you not paying for? Because if it's not related, then you can still get those filled the same way, and it will still be paid for by your Medicare, but it's just outside of that hospice diagnosis. Makes sense? Hopefully I didn't make that too confusing. So, hospice should also be covering all the staffing that we talked about. So hospice, nurse, CNA, social worker, chaplain, medical director, on-call team, and volunteer. That's included. Supplies, those things can be expensive. So hospice companies should be covering incontinence supplies, briefs, diapers, pull-ups, pads to put on the bed, any type of wound care change, because when you get to the point where you are transitioning and you're not eating and you're not drinking and you are more bedbound, it is natural for us to start breaking down. That is not anything that anybody has done wrong. That is really just the way that our bodies are designed. Not everybody has that type of breakdown, but it's pretty common. So if there's any breakdown on the bottom or elbows, I've even seen it behind the ears from the oxygen tubing, that hospice company should be covering those dressings as well, and dressing supplies. Other supplies could be Foley catheters. So any medical supplies that's being brought into your home to help you with the care of that patient, 99% of the time, that hospice is paying for it. Okay, so we talked about pharmacy, nutrition. So nutritional services. We as hospice professionals have mixed opinions on nutrition. That is a big concern for families. My person's not eating, they're not drinking, they're not doing, the things that they normally do. So it's not uncommon, especially if they've lost some weight, for the hospice to provide Ensure, Boost, Glucerna if they are diabetic and can't have all that sugar. But that is up to each hospice company. I've seen some hospice companies that will not cover any of those. So ask those questions as well. Most hospice companies do have a dietary consultant on staff. They're not full-time or even part-time. They're just a consultant. So if you have questions about your loved one's nutritional requirements, then that contracted dietitian can come in and help you make a plan. So with nutrition and hydration, I'm just going to go into a brief little overview of my opinion on it. It's not that it's super, super scientific, but as I was saying before, and I guess I lost my train of thought, we don't require as much nutrition when we come to those final days or even final weeks. Part of what makes your person hospice appropriate is the fact that they have lost weight. That is one of the requirements. Has there been 10% weight loss in the past 6 months? So weight loss is what we expect. When our bodies are transitioning to the point of death, then everything really starts shutting down. Your core organs, or your heart, is really concerned about your heart, your head, your brain, your lungs, and your heart. Not very concerned about your GI tract. Not very concerned with getting circulations down to your fingers and down to your toes. So that's why you will see purple or pale or gray looking extremities or cold extremities, is because that heart is really focused on your brain, lungs, and of course itself, the heart. Kidneys is another thing. They're just not that concerned with the filtration. So you will see patients who are not urinating. They're not going to the bathroom as much. They're not having bowel movements. That's really to be expected in those final days, to final hours. So what happens to that fluid? We're made up of what, 80% fluid? That fluid has got to go somewhere. So where we see that is that fluid can build up in the lungs and develop, you can develop the death rattle. So when you're saying, oh, they're not eating and they're not drinking, know that that is a natural part of this process. There's a reason for it. I like for my hospice patients to be slightly dehydrated, just so those extra symptoms don't show up. Extra symptoms as far as the death rattle. You can see swelling in the hands, feet, face. I've seen it even go so far as what we call third spacing or water blisters, where that fluid is being pushed through the skin, and it's not fun. It's not anything that you want to deal with as a hospice family, because when those water blisters burst, it's not just superficial. They are very deep and what I would picture to be pretty painful. So listen to what your person's body is telling you. They are telling you that they are getting ready. They are telling you that they are transitioning to their final moments. Not eating and not drinking is a big part of that. Each state feels very differently about this topic, and I get that. I hear that some of the northern states and western states even provide IV fluids, and that's fine if that is what your normal is. If that makes you feel better as a hospice family, that is your choice. So going back to, it is y'all's choice, the family's choice of what you want. I have given IV fluids when the patients or the families have demanded it. But then the complications that can come along with that can be pretty unbearable to watch. So, really have that discussion with your loved one before they get to that point on what their desires are. So that's just my thoughts on nutrition and fluids. Counseling and bereavement. We talked about social worker. You should also be meeting a bereavement counselor. That counselor is going to become important to you after your loved one passes, because federally regulated through all the states, hospices are required to follow that family for 13 months. Now, different companies do it in different ways, whether it be phone calls at a set time, cards, visits. You may have your core team of staff come to that funeral. That is bereavement. And they should have memorial services. Not that all of them do, but they should. They should give you that time and that moment to meet back up with your staff, see that nurse, come with that CNA, have those conversations of, oh, do you remember that day that mom did this or that? This is all a part of your healing as a hospice family, is to regroup with that hospice team that hopefully carried you through a beautiful experience, hopefully. So bereavement. If you've never met that bereavement coordinator, before your person passes, and now you've got a stranger walking into your home that you've never met before and you don't have a relationship with, I'm sorry, because they are also a part of that interdisciplinary team, is bereavement services. A lot of good companies, and one that I worked with recently, they had meetings, I think 2 times a month on a Wednesday night. Anyone that was a previous hospice family could come to those grief meetings, bereavement meetings, just to talk about their experience or talk about what they are feeling. Grief is one of the most dangerous emotions to have. I've seen extremely strong people just crumble in their grief and get stuck. And so we all need that professional type counseling to get us through those moments where it's hard, because it does get heavy and it does get hard. Okay, so that's really what hospice covers in a nutshell. Medical equipment, medications, supplies, staffing, and the ability to carry out all 4 levels of care. All of that should be covered at 100% if your payer source is Medicare. If your payer source is Medicaid, it is going to be a little different if you have private insurance and you have to follow those little different sets of rules. Even if you are a indigent patient who does not have the ability to pay, you should still get all of those services that hospice provides. I hope you've enjoyed this video. Kitty's been really good on this one, so I'm pleased. Please leave comments below if you have any questions or concerns about this. I did go into a little bit of what routine home care is about. I'm going to be going into more detail about that in a future video, along with the other levels of care. But hospice does a lot. It really does. We cover a lot. It's a wonderful benefit. And as I said before, it is a gift. It's a gift of a lot of services in your home or in that person's home, whether that be an assisted living facility or skilled nursing facility, that could be and should be free. So ask the questions. Thank y'all for listening. I hope y'all have a wonderful day.